And it's been such a great opportunity. I participated in the first one probably in September, I think. And it was just something that was really a unique perspective. Not only did we go over an article, the author of the article was there, and you got to pick their brain about the way the study was designed and really ask those questions that sometimes when you're looking at an article in your own journal club, like, well, why did they do that? Well, the good news is today we get to ask, well, why did you do it that way? Or what were your thoughts? Or what were some of the problems with the articles or with the study? So it's a really great opportunity. This is the inaugural event for us in a larger format with programs across the country. And so we are pleased to welcome you to the JVS Online Journal Club, really addressing carotid disease this evening. The format of the journal club is going to be to have one clinical article. Tonight, that article is carotid artery plaque the benefit of deferred carotid revascularization in patients with moderate severe disabling cerebral ischemia stroke. And then the basic science article that we're going to look at is a corresponding article from the JVS Vascular Science. It's from 2018, and it is carotid artery plaque echomorphology and its association with histopathologic characteristics. Joining us in the sponsors of tonight's journal club are Houston Methodist Hospital, the DeBakey Heart and Vascular Institute, Dr. Trisha Roy, who is a faculty member there, and her resident, Dr. Paul Haddad. Also, our articles are being sponsored by the Staten Island University Hospital, Dr. Jonathan Schor, and Dr. Mina Gergis. We have special guests as well. We are joined by the authors of the clinical paper, Dr. Rodolfo Mini, and Dr. Fagioli. And to help discuss this paper, B.K. Lau from University of Maryland will be joining us. Just a couple of small housekeeping things. We do ask that you do stay muted the entire time. If you have a question, you can type it into the chat. If time allows, we can have you speak your question. The journal club is being recorded. A link for this will be put up on the website so that you can watch it at later times. And then of course, this is a monthly event. Our next event is going to be scheduled in February 10th at 7 p.m. Eastern. And that is being hosted by Michigan Vascular Center physician, Dr. Mark Matos, who's on the call, and also the Medical University of South Carolina, Elizabeth Genovese, and Dr. Veraswamy is on the call tonight with us from Medical University of South Carolina. So we are going to get started. I'm going to stop sharing my screen and we will let Dr. Roy take over.
Great. Let me share. Can you see my screen okay?
We can.
Perfect. Well, it's such a pleasure to be here. As you mentioned, I'm a surgeon scientist at Houston Methodist, and my focus of research is MRI plaque characterization. So this is a topic that's near and dear to my heart. I think that, imaging characteristics and really using that to guide our treatment is key to us having better outcomes for these patients. So just as a background for our, for our journal club participants, the real holy grail question here is which types of carotid plaques, especially in asymptomatic patients, are going to be at higher risk for patients to stroke. Stroke is obviously one of the most devastating things we deal with as vascular surgeons. And so preventing even a small number of strokes is an important goal. However, even with level 1 randomized controlled trial data, which says that surgery for asymptomatic carotid plaques can be beneficial, when you look at the same data in a different way as presented by Dr. Naylor, you can also see that these same randomized trials are showing us that over 90% of our carotid interventions may be unnecessary. And our guidelines also, nod to that. So the American Heart Association will say, carotid interventions for asymptomatic plaques are recommended in highly selected patients. But who are those highly selected patients? We don't have a really robust way of selecting them. And so, the European Society has their guidelines as well, and they comment on a number of different imaging features that have been associated with high-risk plaques, and one of which the authors of our basic science paper talk about as well. But this is really the key question. Can we use imaging features to predict which are going to be high-risk plaques? And this is really the first step in that, because you have to validate the images that you have, these novel imaging biomarkers, if you will, with histologic characteristics. These are our gold standard histologic characteristics of unstable plaques. So that's what we'll be talking about today. I'm going to hand it over to Dr. Haddad. He's our PGY2 resident extraordinaire. And so I'll let him take over now.
Good evening, everybody. I'm going to be going a little bit more in depth into this paper. I'll be presenting the basic sciences paper that Dr. Roy was just brought up. So essentially the objective of this paper is to determine the association between some ultrasonic texture features previously shown to be independent risk factors for stroke, and then with established histologic features of unstable plaque. Some of the ultrasonic features that this paper dwells into is severity of stenosis, grayscale median, juxtaluminal black area, and then discrete white areas. Just to kind of define these terms, grayscale median is just a way to measure plaque echogenicity on ultrasound, and then your juxtaluminal black areas are hypoechoic areas of plaque, and then lastly, your discrete white areas are going to represent areas of inflammation and unstable plaque. So just briefly going through the methods, this was a single center retrospective cross-sectional study, included about 70 patients, 20 of them were symptomatic, 2 with stroke, and 18 with TIA, 50 were asymptomatic. And then preoperative duplex was performed on all these patients, except for those that couldn't undergo adequate duplex imaging, so the CTA was obtained instead. All of these patients underwent carotid endotherectomy, and then these post-op specimens were sent to the lab and analyzed histopathologically for these things: macrophage infiltration, angiogenesis, and then smooth cell presence. So plaque was also classified. These characteristics that they classified in were fibrous cap, lipid core, size, plaque rupture, and then intraplaque hemorrhage. Monoclonal antibodies were used to kind of tag and identify both these macrophages, CD68, which are associated with inflammation, and then smooth muscle cells as well, and then were graded based on their presence and density. Another aspect that was looked at was the presence and degree of neoangiogenesis, and this was assessed using a digital camera, and that would identify microvessels, and then these images were captured with a microscope and basically magged up to times 400. And these were kind of the images that they came up with, the authors for this paper. Essentially, they used linear scaling with 0 grayscale was used for the blood and was set essentially to 0, and then 190, which was the max of their grayscale, was set for the adventitia. This gave the authors the ability to kind of outline these plaques as a region of interest, and then extract kind of texture features from them to try to establish, these different types of plaque that I referenced earlier. As you can see here on the left, so you're going to see what we talked about, discrete white areas. Mostly are going to be these areas in red, which they use to help us just kind of look at these a little bit better. And then obviously the white here, but with this colored view, you can see it more clearly. And then over here, the juxtaluminal black areas are identified as well. And then there are obviously some discrete white areas here as well. So these are essentially the images that they obtained when analyzing these plaques. So a couple of tables in this paper. Essentially, this first table, listed the prevalence of risk factors that are commonly known medical treatment comorbidities between symptomatic and asymptomatic patients, and then between patients with stable and unstable plaque. Most notably, that this kind of table references is the amount of statin therapy that asymptomatic patients were known to be on, which came on at 64%, and then symptomatic patients that were, most of them were not on statin therapy, about 15%. And then this table also had significant findings for patients with stable plaque and unstable plaque, found that statin therapy was not significantly different between the two, which was interesting. So next, this table looked at this association between histologic features and ultrasonic plaque texture features. The low grayscale median was found to have high-grade macrophage infiltration, which you can see here, a small number of smooth muscle cells, a higher grade of neovascularization, a larger lipid core, a thinner fibrous cap, presence of intraplaque hemorrhage and plaque rupture, as well as instability. So those were features that, low grayscale median, low exogenicity was found in these, was found to be associated with these things. Also notable was that juxtaluminal black areas greater than 8 millimeters squared were found to also be associated with large lipid core size, as well as plaque rupture. So moving on, this kind of gets more into the juxtaluminal black areas. They're associated with low levels of smooth muscle cells, a larger lipid core, and then a higher prevalence of plaque rupture. Plaques were generally considered or classified as unstable when they had these features. And then both the combination of a thin fibrous cap with a large lipid core and the combination of a thin fibrous cap with plaque rupture were associated with the highest prevalence of juxtaluminal black areas. So last table here for you guys talks about the statin therapy in relation to histologic features. And essentially, statin therapy was associated with a low grade of macrophage infiltration, higher number of smooth muscle cells, and a lower level of neovascularization, essentially saying that statin therapy, as is commonly known, helps with broader inflammation and improves plaque stability. So like I said earlier, low grayscale median is associated with histologically unstable plaques. These were found to be thin, large lipid cores with a small number of smooth muscle cells, increased inflammation, and then findings essentially with an end result of inflammation and intraplaque hemorrhage and possible plaque rupture. So high numbers of smooth muscle cells were associated with high grayscale median and histologically stable plaques. And then all histologic features characterizing unstable plaques were associated with the presence of discrete white areas. Lastly, juxtaluminal black areas were associated with a larger lipid core and plaque rupture, and its highest prevalence, 65%, was found in plaques with a thin fibrous cap and a large lipid core. Plaques with a thin, this was also found with plaques with a thin fibrous cap and plaque rupture. So just some limitations that the authors definitely state, and I'm reiterating now, is that statin therapy was administered to 64% of asymptomatic patients, and only 15% of symptomatic patients were on statins. Statins affect the presence of inflammation in the plaque and the effect on macrophage infiltration, number of smooth cells, and neovascularization. So that's definitely something that could affect the outcomes found in this paper. Again, this paper also only had about 70 patients, which is a small number. And then one other thing that this paper notes is the time interval between symptoms and endotherectomy as a potentially playing a role, since longer time between symptoms and commencement of statin therapy may increase plaque stability. So essentially this paper, was important in that it did identify ultrasonic features that are known to be associated with unstable plaque with symptomatic patients, and it helped to stratify asymptomatic patients into different classes of stroke risk with a strong association established histologic features of plaque instability. That's essentially the main points of this paper. Yeah.
Thank you, Dr. Haddad. I appreciate you you going through that so thoroughly. We do have a couple of questions, and I think that these are questions that I'd like to have either yourself or Dr. Roy or maybe even BK kind of comment on. And the first question is, are any of these features of duplex ultrasound that are easily and routinely obtained in our current studies? Dr. Roy, maybe you can address that.
Yeah, so these authors have developed proprietary software which analyzes the images, normalizes it in the way that he was showing. So this isn't something that is available routinely. You do have to use that software, and the idea is then you should be able to use it with different ultrasound machines, different ambient lighting, different kind of settings that typically would alter your imaging features if you use this specific software. So that was my understanding in looking at their previous work and this paper as well.
And Dr. Johnson also asked, can manipulation of the plaque during the operation potentially impact the histological evaluation at all? I mean, I know I've taken out some plaque and given it to some of our researchers, and when I do, they struggle with the plaque sometimes to decalcify it and all kind of different things. But do you think that the manipulation in the surgery could have affected some of what they see histologically?
Absolutely. I think that one of the ways, at least in our imaging, when we're looking at ex vivo plaque, we will repeat our imaging. So I talked to Dr. Garami, who runs our vascular lab and is on the line right now. And how they went around that is that after excising the plaque, they would put it into an agar gel, repeat your ultrasound so that you have another understanding of what the features are as the ex vivo plaque, and then do your histologic processing. So I think that that's a good way of being able to line that up a bit more. Sorry, my dog just came in. But yeah, I think that you can end up, and you do have to decalcify all of your lesions as well in order to do your histologic processing. So that changes things as well.
I just would like to add, this is Jolt, that I think in the method, it really bothered me that there was only 5 section done, that one at the most critical stenosis and 1 centimeter and 2 centimeters from that critical stenosis. So I wouldn't be surprised if would be an honest paper saying that at 2 centimeters you'd had nothing to analyze. And I think those are the things that I really wanted to point out, that everybody please look up reference number 13. This is Dr. Law's paper from 2002. He had a different idea with a grayscale. So this is where I say that somebody in Greece is colorblind already, because they used only 0 to 190. Our ultrasound machine is done 0 to 255. So those are limitations, almost like you want to ignore certain numbers, and that probably will give you some limitation. It's already hard to recognize those grayscale, median, and the low level. And I think that's another history I want to tell you, that on SBU meeting 1 year, the low GSM score was 40. Next year was 25. So I think right now, I remember Dr. Law's paper was, I think, 32, but I'm really interested to hear more from him, because I think that paper from 2002 is really, I want you guys to put those images from 2002, and so much easier to see the measurement. And I think we will laugh that there was a Photoshop and Adobe, but it's really doable. So you don't need a fancy proprietary software. You can do it in your garage with a Photoshop or JImage, something that I think just really tricky, how you have to align those grayscale median to the right colors. Thank you.
So I'll jump in. Thanks, Zolt and Trisha. I want to congratulate the authors. I think that this is a well-performed analysis, well-performed histology, well-performed images. But as Zolt and Trisha pointed out, there's always things that we can discuss and talk about. I think all of us agree that B mode images are representative of gross anatomy. I think we wouldn't be looking at B mode images if that relationship didn't exist. I think one of the steps forward in this paper is that it's showing that B mode images are also representative of specific histological and, in fact, perhaps even activated cellular pathology. That's the interesting finding. The two challenges are essentially, how do you collect the ultrasound images in a standardized fashion? And how do you acknowledge the fact that B mode images are two-dimensional in this paper and in most imaging that we perform, whereas the lesion is three-dimensional? So I'll talk a little bit about standardization of image capture. I think our European colleagues have been far better in trying to come up with more standardized ways of performing ultrasonography of the carotid. And I think there's a long history of that, something that we have not been able to replicate within the United States. There are centers that perform very high quality, very reliable imaging. And then when the moment you move to a multi-center study, the analyses essentially become very, very variable. They vary between machines, they vary between operators, and therefore morphological assessments are virtually impossible. And so this is a big challenge. The second challenge is that because of calcification and because of imaging angles, it's very difficult to come up with duplicatable two-dimensional images. And I have an inherent concern that when you're looking at a cancer, how can you, which is a three-dimensional lesion, how can you rely on a single two-dimensional slice to say whether a cancer exists or not? And the same holds true within these plaque lesions. You may entirely miss a very dark area in the plaque or a very bright area in the plaque. So those are some of the inherent challenges of B mode imaging. What I do find exciting in this paper, though, is the relationship between whatever limited imaging was available and analyzable, and the fact that there was a correlation existing between activated cellular pathology. To me, that's a big step forward.
Thank you. I think there's a lot that we want to discover or discuss here, and I'd like us to go through the next paper first, and then we can kind of come back around to some of that. So Dr. Schor, I think that you're going to introduce our next paper.
Let me get my screen share working. Can everyone see my screen there?
We can.
Okay, good. Okay. So I'm going to introduce the next paper, which is the benefit of deferred carotid revascularization in patients with moderate to severe disabling cerebral ischemic stroke by Dr. Pena et al. And it's an article in Press for JVS from 2020. And first of all, I just want to acknowledge and thank our Italian colleagues for coming on. It is 2 o'clock and now 2:30 in the morning for them. So I appreciate them coming on to help us discuss their work. So just a little background, NASIT and ECST established that there was a significant benefit of carotid endotherectomy in symptomatic high-grade carotid stenosis. However, during the paper, there was no established time frame between symptomatology and carotid intervention. The time between symptoms and intervention were not noted to be a significant risk factor, but it was not standardized across the patient population. It was not a risk factor for stroke death or MI. NASIT did not stratify either by stroke severity. So all patients, all comers were subject to the same analysis, and there was no stratification of the patients who had severe, moderate, or just a mild or TIA. Recommendations since then have established that early intervention is warranted, and Dr. Naylor wrote a number of papers about this with regards to patients with recent TIA or a mild stroke. However, in the case of a moderate to severe stroke, multiple studies have established that surgical outcomes are improved with a delayed CEA. And one of them came from one of my alma mater, Dr. Rockman from NYU, who was, her paper was an instrumental paper in changing the way that we approached carotid endarterectomy. And of course, there was no clear indication is established with regard to timing of intervention. So, and now I'll let the paper aimed to look at that and to find out what in a patient with a severe stroke, when is the timing appropriate to perform the carotid endarterectomy? And I'll turn it over to Dr. Gurgis, who will take over and discuss the paper. Stop the screen share
here. Thank you, Dr. Schor. Good evening. My name is Mina Gurgis. I'm a vascular surgery fellow at Staten University Hospital. Thank you very much for allowing me to participate today. It's an absolute pleasure to present this article. As Dr. Schor mentioned, and I'll just reiterate, that the correct timing for intervention, especially in this group, being large volume cerebral ischemic lesions as defined of more than 4,000 cubic millimeter, and moderate or severe stroke as defined by a modified Rankin scale of more than or equal to 3, is lacking. Therefore, the aim of the authors was to determine the most appropriate timing for carotid endarterectomy in patients with a recent moderate stroke and large volume cerebral ischemic lesions. Data including clinical characteristics, technical aspects, and perioperative outcome in terms of stroke or worsening of cerebral symptoms with the increase of at least 1 modified Rankin scale grade and death were collected from 2 tertiary centers from January 2007 to December 2017 and studied retrospectively. All patients had preoperative neurological clinical evaluation performed before and after carotid revascularization by an in-house neurologist using the modified Rankin scale. Cerebral CT scans were performed at onset and 48 to 72 hours later, together with CT angio of the supraortic trunks and of the cerebral vessels, and a volume of 4,000 cubic millimeter was considered a risk factor for postoperative complication. And this number was set by the group from a previous publication. Intervention was performed under antiplatelet therapy and general anesthesia using routine shunting and Dacron patching or eversion endarterectomy. The timing of symptoms to surgery varied, but the revascularization procedure was performed only when the neurological condition was stable and the cerebral ischemic lesion was stable on CT scan. For reference, this is the modified Rankin scale, and the group of patients we're talking about fell into grade 3 or grade 4. Inclusion criteria were cerebral ischemic stroke with a modified Rankin scale score of 3 or 4, volume of the cerebral ischemic lesion greater than or equal 4,000 cubic millimeter by CT scan, and ipsilateral carotid stenosis greater than 50%. Exclusion criteria were dementia or short life expectancy less than 1 year, severe comorbidities, or just refusal of the patient to undergo surgery. Patients unfit for surgery or excluded patients were followed for 1 year to evaluate the recurrence of symptoms or neurological deterioration. Here are the preoperative characteristics. In total, there were 126 patients with the moderate stroke and large volume cerebral ischemic lesions. The median age was 69, most were male. The median volume was about 20,000 cubic millimeter. The median time elapsed from symptoms to surgery was about 7 weeks, and the median score was 3, and that score did not change from the time of symptoms to surgery. Overall, the perioperative stroke death was 7.1%. 2 hemorrhagic conversions of the previous stroke after 1 and 2 weeks, worsening of symptoms in 2 patients from grade 3 to 4 without any evidence of deterioration on CT scan. And these patients returned to baseline after 2 days. 2 new neurological events without significant change on the postoperative CT scans, and 2 new ischemic strokes associated with new cerebral ischemia lesions on the postoperative CT scan. There was 1 fatality due to MI 15 days after surgery. Patients submitted to carotid endotherectomy within and after 4 weeks of symptom onset had similar clinical characteristics and large volume cerebral ischemic lesion. And the 4 weeks came from this evaluation. This is an investigation for the best timing for carotid endotherectomy. And this is performed by evaluation of the higher difference in the post-operative carotid endotherectomy outcome in the early and late periods, considering every week after the event for the first 8 weeks. The highest significant difference was identified 4 weeks after the symptom onset, thus suggesting a better outcome of patients submitted to delayed carotid endotherectomy after 4 weeks compared with patients before 4 weeks. And this is determined by the area under the curve here, which is the greatest at 4 weeks. Surgery performed within 4 weeks was associated with a significantly higher rate of stroke death compared with patients operated on after 4 weeks, as demonstrated here. This was stroke or death. By logistic regression, carotid endotherectomy within 4 weeks was a significant risk factor with an odds ratio of 8.3, and for post-operative stroke or death. And this was independent of sex, cerebral ischemic lesion volume, dyslipidemia, and carotid stenosis. To demonstrate the difference in outcome between the no surgery and the surgery group, this table was shown. All patients submitted to carotid endotherectomy were followed up for at least 1 year. In the no surgery group of patients, no other strokes occurred. About 101 patients were considered unfit for carotid endotherectomy because of either dementia, severe comorbidities, or short life expectancy. This group of patients, as demonstrated here, were generally older in age, had a significantly higher rate of comorbidities compared with patients submitted to surgery. In the cohort of patients unfit for carotid endotherectomy, there were 6 stroke recurrences, 1 at 2 months, 2 at 5 months, 2 at 7 months, and 1 at 10 months from the index event. The comparison of stroke rate in patients submitted to surgery versus the control group did not show statistical significance in terms of stroke rate, but they did compare patients who underwent surgery after 4 weeks with the control group, and they actually found a reduction in events in patients submitted to surgery, 1.7% versus 13.9% in the control group. The study conducted a selected group of patients not frequently analyzed in the literature. The authors also considered large volume cerebral ischemic lesion. Actually, few studies in the literature evaluated the influence of the volume of the cerebral ischemic lesion on carotid endotherectomy outcome. It has been cited that for each centimeter of the cerebral lesion, it seems to increase the risk of postoperative major events by an odds ratio of 1.7. And this group previously published that 4,000 cubic millimeter was determined to be the threshold for an increased perioperative risk. Well, waiting period for 4 weeks left the patient susceptible to recurrence of stroke. However, there were no new events that occurred, and the authors put forth a few explanations. One is that the stroke severity was determined by damage massive enough to prevent symptom recurrence by subsequent smaller embolizations. 2, the moderate to severe disability can hide other smaller events. It is pretty clear, however, that there are benefits with delayed treatment, and that patients treated with the earlier period within 4 weeks suffered a significantly higher rate of postoperative stroke or death compared with patients operated on later, and the number was 11.9 versus 1.7%. There are limitations to this study, however, mainly being retrospective in nature. A randomized control group is needed to further make a determination on the standard of care in this particular group of patients. Furthermore, the timing of intervention varied. In conclusion, this is an excellent article, clearly demonstrating that there is indeed benefit to delaying surgery in this particular group of patients who have not been extensively studied in the literature. It is also important when taking care of these patients to do so with multidisciplinary team involvement, the surgeon, the neurologist, with follow-up imaging to determine the appropriate timing. Thank you again for providing us with this article. I enjoyed reading it and presenting it. And I'll stop my screen now.
Thank you very much. I'd like to first ask Dr. Pini to make some comments. I would really like to hear some of your thoughts, perspectives as the lead author on this paper.
Yeah, thank you, and congratulations for the presentation, first of all. And the study came from a routinely question from our group when to treat patient with severe stroke, and in the European and also American guidelines have not indication for the timing to treatment. That's because the two big trials for symptomatic patients, the NICHET and the ACCT, the American and the European trial on symptomatic carotid stenosis, did not include this group of patients with moderate severe stroke. So we are with a group of patients not studied in the literature. This was the first element. The second element is regarding our results, and you can see an overall stroke rate high. It's about 7% stroke and death. It is higher than the recommendation of the 6% for intervention in symptomatic patients for a benefit from the intervention. But I remember again that this group of patients, this threshold of 6% came from patients with minor stroke, not from this group of patients. Probably this group of patients has a higher risk. And let's talk about.
Dr. DiMuzio, you had a question that you put into the chat. Would you like to unmute yourself and ask it?
Yeah, I mean, for the older surgeons on the call, we were always taught that after a major stroke, we would wait 6 weeks for intervention. And after looking into that as to why 6 weeks was picked, it was my understanding that 6 weeks was then where the brain appeared to take its final status after a stroke at 6 weeks, if you followed it serially on CAT scanning. So I'm wondering from the authors why they think the long wait is appropriate. Is that because the brain is finally stabilized, and is this basically an anatomic or physiologic process? But congratulations on examining a cohort of patients that we don't always think about often, but thank you for bringing it to our attention.
You're welcome. Your question is completely right, and we don't know exactly why the threshold of 4 weeks came from the data from statistical analysis, but probably the amelioration of the medical therapies and the clinical improvement in the management of patients with strokes can have some benefit in the brain tissue outcome after the stroke. This is the only explanation that I can speculate on the reason for this reduction on the weeks from the stabilization of the neurological event.
So Paul, in answer to your question, I think there have been some very elegant studies looking at restitution of blood-brain barrier and reduction of cellular edema after an acute infarction and the time course. And it turns out that the time course actually mirrors what we as vascular surgeons have learned intuitively over the years and decades. And there's actually a plateauing of recovery of the blood-brain barrier restitution and edema resolution around the 4 to 8 week mark after a general. I did want to bring in. Is everyone hearing?
You might need to mute everybody if you can, if you're not muted, just so we don't hear an echo.
I generally don't even like to hear my voice once, and now I'm hearing it twice over. I want to congratulate the authors for actually trying to bring some objectivity to something that for decades and perhaps generations has been a very subjective decision. My patient, quote unquote, looks better, or my patient's stroke has, quote unquote, stabilized, so now I can go ahead and operate on her or him. And we're trying to bring some objectivity to this. So I congratulate the authors for doing that. I do have a couple of questions. The impetus for this has actually come from the more recent experience over the last decade on intracranial thrombectomy for acute strokes, and an attempt to try and risk stratify patients to decide whether to go ahead and perform the intracranial thrombectomy or not. And when you look at that literature, it's become apparent that it's not just the infarct size, but also the size of the penumbra. In other words, the threatened brain tissue, not the dead brain tissue, that is important. And also the location or the topography of where the infarct occurred in the brain. Less eloquent areas versus more eloquent areas, deep-seated areas versus superficial areas. And then also the effectiveness or completeness of the collateral circuit, the circle of Willis, in order to provide collateral circulation during the time that the carotid is clamped, for instance. So have you have this information. So my recommendation to the authors is to actually factor that in to your analysis, and you're probably going to find that your predictive ability is going to improve. The second point I wanted to make was that I have to say again that I congratulate our European colleagues. 11 years ago, and you were collecting modified Rankin scores on your patients. That's phenomenal. We can barely get that even now in the United States in a standardized fashion in all our patients. So fantastic. This is something we have to learn from. However, I do want to point out that modified Rankin score is a better predictor of long-term outcome after a stroke. The NIH stroke scale is a better predictor of short-term outcome after a stroke. So I'm not sure if you have NIH stroke scales, but again, I would recommend you draw correlations between the NIH stroke scale as a function of stroke severity in your decision-making algorithm. Great paper, I liked it.
Thank you for your kind words. And both your questions are right and perfectly explained. The first is about penumbra, location, and the collateralization of the Willis cycles, and it's completely right. About penumbra, we did not, this study came from this experience of the evaluation of the volume of the lesion in our single center. So we increase the group of patients evaluated, also another hospital in the same city, that but the data was different, and we did not have the evaluation of the penumbra from all the cohort of patients. So it's a correct, extremely correct question, your question, but we did not have this data. And moreover, I want to underline that in 11 years period, we included only about 100 patients submitted to endotherectomy. So in 2 centers, so a group of patients extremely low, and these different characteristics that are extremely important for the clinical analysis did not have a statistical power for the evaluation. We have to improve our group of patients and improve the number of characteristics for the analysis to have some robust data on these elements. And for the second question, and I thank you for the acknowledgement for our database. But I want to underline that the modified ranking scale is much more easier to evaluate and register. And that's why we have this data from long period, from 11 period. The NHS is, of course, more detailed. We can have some correlation with that, but it's not correct to have a correlation. And again, we have an analysis and results from 2 different centers, and not both centers have reported in their database this data. So it's the reason that we did not have this particular data on our group of patients, but it's extremely correct. We have a comment in our discussion about this aspect and the correlation with these 2 scales, but it's not correct to compare the 2 scales. You're right.
Can I just add a little comment also to interact with everybody and to answer to some questions in the chat? I would like to stress what Rodolfo has said up to now. This is a particular set of patients. Those are just very unstable patient. Well, not exactly unstable, but those patients are, as Rodolfo said, a patient with ranking score 3 and 4, and this is for answering to Dr. Glowicki question in the chat, asking an analysis of patient within the first 2 days after stroke. And as our ROC curve is showing, really the first days in these patients with large volume, those are patients with ranking score 3 and 4 and large volume lesions. And this is a very specific set of patients. I agree that with the smaller lesions and with lower severity of the stroke, you should intervene earlier. And this is our attitude too. But those are very sick patients, and these are the data we should look at. And we don't have to mess up and confound different categories of patients.
Dr. Fagioli, I really appreciate you saying that, because I was going to combine some of the questions in the comment. And I think that's what confuses people sometimes is, you know, in the JVS, Dr. Glowicki, the editor, there was an article that was published, or a manuscript that was published this year saying operate within 2 weeks. And now I got an manuscript saying operate in 4 weeks. And to really understand, we're separating the populations. We're dissecting this a little bit more. And so I do think that it's really important to focus on which group this is. And I'd appreciate it too if, and you know, in BK just a few minutes ago talks about, you know, 4 to 8 weeks in the recovery. And I think that's important. Do you worry about hemorrhagic conversion in some of these larger stroke patients? And is that part of the reason why we need to wait a little bit?
Well, I think that in those patients, you have to combine, as Dr. Lal said before, you have I agree with him that you have to be objective and you can't rely only on your experience. But again, I think that you have to mix up your clinical judgment with the type of lesion. If the lesion is very large, then hemorrhagic conversion can be a concern. However, again, you have to decide what to do when the patient is stable. I think that this is something that you cannot really decide with a retrospective study as our study was. So this is our big limitation, because I think you have to decide what to do with the patient, also looking at the fluctuation of the symptom and the clinical stability of these patients, also considering the volume of the lesion.
So I think there are two considerations that are driving this discussion. The first concern is, during the revascularization, are we going to encounter hemorrhagic conversion? And then the second is, as a result of the revascularization, are we going to extend the infarct? Those are our two big concerns. I think there's a general relationship between size of the infarct and risk for hemorrhagic conversion, but we know very little about what other factors impact the risk for hemorrhagic conversion. In terms of size of infarct extension, however, we've learned a lot more. And it's not just the original size of the infarct that predicts infarct extension, but also the size of the threatened brain tissue surrounding the infarct that drives the risk for infarct extension. And once we acknowledge that fact, then we've got to start looking at diffusion-weighted imaging that can identify the size of the penumbra, and also anatomic imaging to look at the completeness or patency of collateral, cross-collateral circulation that will protect that. So I think that this is step number one, and it's a great step, but I think that we need to continue to increase the sophistication of this risk stratification so that we can come up with more objective measures. And we'll see that we'll probably end up with identifying patients that can be operated within 2 weeks with the same volume infarct versus a patient with the exact same volume infarct that we may decide to wait for 6 weeks because there are so many other factors involved.
I would like to suggest a nice objective way of measuring it. I learned it from my Italian neurologist colleagues, breath holding test. I think Dr. Silvestrini in Rome and Baracchini in Padua, they showed me how to do a breath holding test, that you test autoregulation. Second, that you know what is your MCA is open or not. So you really are combining a really objective way, helping your decision. And I think, Dr. Lal, that to see that the autoregulation is intact after your brain barrier suffered, that would be an easy way and objectively to confirm with this breath holding test. So I think congratulations to also involving your neurologist in the decision making, because I think this is where they have a tool with the transcranial Doppler that they can help you with the decision. Congratulations, and thank you for staying up.
Thank you. We had a little sleep before the meeting, though.
Dr. Glowicki and Dr. Mattis, you both have a couple of questions. And Dr. Glowicki, if you want to unmute yourself and ask your question, and then we'll go to Dr. Mattis. I want to get you both in before the end of the hour.
Well, I just want to congratulate Dr. Pini and Gianluca Fagioli for an excellent paper. And I think we all realize that this is a different group of patients that we usually operate, because in the usual symptomatic group, indeed, after 48 hours of delay, we did not find any significant difference in stroke and death rate. So my question is this 4 weeks something that is arbitrary, like is it maybe 2 weeks or maybe 6 weeks? And I think it would be worthwhile to really do a little bit, scrutinize the data to see if 4 weeks is the right time, or maybe there are other factors that affect stroke and death than the 4-week period.
I'll jump in. Peter, I would predict that if we were to alter the volume of the infarct size as a threshold, we'll end up with different time periods. So in other words, the threshold here, or the cutoff here, is 4 ml for the stroke volume. If we drop it to 3 ml, we'll get an earlier time period. And if we raise it to 10 ml, we'll get a different time period. So I think that you're absolutely right. We need a larger study with a larger number of patients where we can actually look at this as a continuous variable and draw relationships between increasing size of infarct versus the optimal time that an intervention should be conducted. It's a very good point.
Dr. Mattis?
Thanks, Missy. Very nice paper and great discussion. I think from a practical point of view, as my fellows go out on their own in 8 months, and they're asked to treat somebody with this kind of cerebral vascular disease, and are they going to do it at 2 weeks, 4 weeks, 6 weeks, and 8 weeks? And how are they going to determine that in their 200-bed hospital? And what kind of stroke rate's going to be acceptable for somebody at 2 weeks, 4 weeks, 6 weeks? Because there's data out there that suggests publicly that if you have a higher stroke risk, you tend to get a negative sort of referral pattern because you've actually taken care of somebody who's has a more difficult recovery period, and pretty soon you're the surgeon with the high stroke risk. So I'm interested to sort of see how that may affect people's treating these at 2 weeks and 4 weeks. And then the other thing is, what's really the risk of the contralateral disease in the intracranial circulation? What effect does a complete circle of Willis have or not in terms of how the outcome is based on when you treat people? And all those questions I don't think are answered yet in this paper or any other paper that talks about timing, either for amaurosis, small non-disabling stroke, TIA, or fixed stroke deficit. But thank you. It was a great conversation. We just had a controversial topics conference on this last night, and it was eye-opening. So, anybody have any ideas about what they would consider an acceptable stroke risk? I'd like to poll the audience. What do you tell your patients?
Mark, I would not hazard a guess on that because I don't think we have the data to be able to really come up with a real number. If you were to ask me, what I do personally is I quote much higher stroke rates in that time period. With respect to your other question, we don't have a direct answer on what the relationship between carotid endotherectomy or carotid revascularization and periprocedural stroke in these patients is. But we have some fairly good data that we can lean on indirectly on intracranial thrombectomy and the risk of progression of stroke in the absence of a complete or intact circle of Willis, or in the presence of a contralateral carotid occlusion. And the stroke progression rates double in the presence of those. So we know that. Now, obviously, that information does not translate completely into a carotid revascularization procedure, but it is informative. It does tell you that the penumbra matters. It's not just the infarct volume. It's the volume of brain at risk.
Mark, one of the conversations that I have in doing endotherectomy after a stroke is when you wake up, you may replay your stroke. And as we know, that is an incredible stress on us as surgeons because we're sitting there with somebody who had significant right hemiparesis. We operate on their left carotid, and now they're waking up with a more, they've replayed the right weakness, but hopefully in a day or so that comes back and it's mission accomplished. We're preventing recurrent stroke. So in general, it's really a vague thing to discuss with patients, but my hope is as we get farther out, 4 to 6 weeks after a significant stroke, that replaying is much more downplayed. And if I have a neurologic deficit, at that point, I'm really actively looking, boy, did I mess up. and we need to reopen the carotid or whatever. But it's a hairy thing, and no matter how old you get and experience you get in doing carotid disease, you don't get used to waiting for that person to wake up, you know, and see how they do. But congratulations to our folks to shed some light on this.
Thanks, Paul.
Well, thank you everybody for staying with us a little bit over the hour. I especially, of course, want to thank Dr. Pini and Dr. Fagioli. It's 2:30. It's now 3 o'clock in the morning. We are very grateful also to our host institutions, Houston Methodist, DeBakey Heart Center, and also to Norwell Program in Staten Island. Just a great discussion. Of course, BK, always, you may not like to hear your voice, but I do. I learn so much every time. I really do. And I think it really enlightens me. So we are going to be hosting the next one in February. You can look for that announcement on social media. We are going to have a website also up, which will have a link to register. And Dr. Mattis and Dr. Genovese will be hosting that from Michigan and also from MUSC. So thank you all. Have a wonderful night.
Thanks, Misty. Thanks, Paul. See you guys.
Thanks, Misty.
Thank you very much. Bye.
God bless.